Dear pure urology viewers, good evening, one and all. Today, like any other day, we are discussing on the surgical technology. Today, our topic is again PCNL. As you all know, PCNL is the one surgery which is very commonly done by the urologists. Some are trained by their bosses in a proper manner. Some have learnt after MCH, some have practiced by seeing others. Usually, it is considered as a semi blind procedure. In RIRS, you will see the stone and pulverize. In TURP, you see the prostate gland and you cut it. But in stone, uh, we have to in PCNL stone surgery, we have to think before you puncture. The day when you get clear urine, you pass a guide wire and you say that I am successful surgeon. The day you get blood, people say you are unsuccessful surgeon. The calyx, the anatomy, the puncture, the direction, everything are important. We also think that it is semi blind, but recently, around 4 years back, first time I met our speaker today, Gyanendra Sharma sir. Before that, I did not know actually. Unfortunately, I was there in practice for 10 years. He is a very well known urologist in the West Zone, practicing in Sholapur, and he is an excellent speaker, knowledgeable person. And after interacting 2 3 sessions, we understand that how much deep he goes into the subject. His other area of interest is also hypospadias, but today we will stick on to the PCNL. He has done a lot of work on how, in triangulation technique, the mathematical application of the angles will help us to reach the calyx in appropriate. We don't do everything, but understand that you will perform better. So, with this introduction, I will ask Gyanendra Sharma sir how he got this idea, and then I will introduce and proceed for the talk. Good evening, sir. Gyanendra Sharma sir.
Good evening, sir.
Thank you for accepting the invitation in Pure. It is a actually delayed program. I might have done it way before, but good that we realized, and it will be very helpful for the juniors. So I wanted to ask you briefly about your career. Where did you do your MBBS and MS, sir?
I did my MBBS and MS from Dr. Vaishampayan Government Medical College at Sholapur. In fact,
Oh,
I
very
had
good.
done my schooling from Bombay, and then from 11th onwards, I was in Sholapur. And after my MS in general surgery, then I did my MCH from JJ Group of Hospitals, and I worked at St. George under Dr. A.V. Rao. A.V. Rao, sir.
Great. Who was your mentor in PCNL? Did you do in PCNL during your training, or after that you learnt your PCNL?
Sir, interestingly, I did not do a single PCNL in my
Yeah,
MCH.
yeah. Most of the times it happens of your generation and my generation also.
Yes,
Unfortunately, that time our bosses also used to little experiment. Then when
yes.
we expect as residents, impossible.
Very honestly, though I did answer questions on PCNL in my DNB exam when Mahesh Desai sir was my examiner, I
Very
honestly
good.
would say that I did not understand PCNL that time. And I would give enormous credit to Dr. Pankaj Maheshwari, who initiated me and made me realize what PCNL is and taught me the basic things about PCNL.
Very
So
nice.
he has been my mentor in PCNL, and over a period of time, a very close friend of mine.
Great. He is also like that. Enucleation also we have seen certain surgeries from him.
Yes.
Gentleman, and he never hesitates to share the work and
Absolutely.
concepts with others. And after MCH, your Solapur is your native place?
No, sir. Basically, like my grandparents, parents all had done their education in Bombay.
Hmm.
I also did my schooling in Bombay, but my father was transferred. He was an oral surgeon. He was transferred to Sholapur when I was in my school. And so 11th onwards, I decided to stay in Sholapur. And interestingly, I like this place far more than Bombay. So I decided to settle here.
Solapur is a big place. And after how many years you got the grip on PCNL? Initially, you might have hesitated to puncture and do a large stone naturally.
Sir,
So,
very correct. And very honestly, I would say that I started my practice in 1999.
Sir.
And for the first couple of years, in fact, you are trying to build your roots and hardly getting any patients also. So
Yes, yes.
it was in the initial part of the from 2001 to 2004 onwards that I started my journey of PCNL. But
Very good.
independently, honestly, when the work started improving in my private practice, because I immediately after my MCH, I started practice. I never worked at any other institute.
Same, me too, sir.
Yeah,
Then I understand the difficulties of establishing the practice in small.
exactly.
Yeah.
So 2001 onwards, I got initiated to PCNL, and then independently, I started doing it from 2005-6 onwards. When I started understanding it in a better way as I came across more and more cases, and I realized that the biggest problem when you talk to anybody is the learning curve. In fact, I had also been to Nadiad for 15 days. I should give credit to Sabnis sir, Dr. Ajay Oswal, Dr. Mukund Andankar, who all at some or other stage have given me some or other inputs. So
Yeah.
the base which was formed by Dr. Pankaj Maheshwari,
Hmm.
I took help from a lot of people, kept on reading, and then I came up with certain ideas of my own, which helped me a lot in overcoming my hesitation and shortening the learning curve also.
Honestly, I will ask: are you a triangulation surgeon or bullseye, or you use both?
Sir, I would prefer triangulation always, except in the middle pole where everybody would do a bullseye. But otherwise, given a choice, if I am doing a prone PCNL,
Yes.
uh, about 70% or more of the times I do a supracostal puncture. Uh,
Hmm.
Most of the other times it might be a lower pole or a mid pole puncture, but
Okay.
preferably triangulation.
Triangulation. And with that, I will introduce you officially, and then we will go to the program. I will hand over the program. Thank you once again. So, dear viewers, naturally, I feel PCNL is the one surgery in urology. Even as of today, I accept that you should be well versed to succeed in practice, because all the cases you cannot do RIRS. So PCNL is a must surgery for your practice. Even in for government institutions, for you to teach, you need to have good skill. Even robotic surgeons does some, uro oncologist does some PCNL to do the work going on. Simplified mathematical way to determine site and angle of puncture in triangulation technique of percutaneous renal axis is the today's talk by Dr. Gyanendra Sharma sir. Dr. Gyanendra Sharma is consultant urologist at Chitale Clinic, Solapur, Maharashtra. Previously worked as assistant honorary professor in urology, Dr. Vaishampian Memorial Government Medical College, same Solapur. Interest in doing pediatric urology, hypospadias, and various endourological procedures, especially PCNL. Members of the editorial committee of Indian Journal of Urology since 2016. Board member of Indian School of Urology, Urology Society of India. His technique of percutaneous renal axis is described as the hybrid technique and is mentioned in the Smith's textbook of endourology. His article of hypospadias repair in adults is cited in 10th edition of Campbell's Urology. Oh, great! His technique is recognized by the European Society of Urotechnology as one of the four techniques for percutaneous renal access. He has more than 30 publications in many national and international journals. I really appreciate the way you are into academics being in Sholapur. Really, really great. And I thank once again and hand over the program to you. Please take your time, sir. We are not in hurry. Already, honestly, 65 people are online. They quickly add once you start the program. So let's hope all the juniors get the benefit out of this talk. Thank you very much.
Thank you, sir. It's indeed a pleasure and privilege to be part of this great initiative by you. And I'm really indebted, and I think the urology fraternity is indebted to this great initiative of yours, which has helped in overcoming a lot of teething troubles which a lot of urologists keep on facing. Uh, I would be sharing my screen, and is it visible, sir?
Ah, yes.
Yeah,
Enlarge the screen, sir.
yes, sir.
Right, sir.
It's not seen.
No problem. Reshare again.
Yeah.
Already keep in the enlarged view, then it will come easy. Roll, sir. Roll one slide. Let us see.
Okay. Okay. Okay.
First, you enlarge the view in the PowerPoint presentation
Yes. Yes.
before sharing. Directly go to that.
Yeah. Is it visible now, sir?
Fantastic. No
Yeah.
problem.
Well, there are no disclosures from my side, and I would like to acknowledge Video Urology Journal for giving me permission to use the video which I had submitted to them, and they accepted in 2017. It's the same video on hybrid technique. The objective of my talk is how do we identify the posterior calyx? Because in a prone PCNL, this is the first thing that will come to the mind of any surgeon who would be puncturing the calyx. So how do we identify the posterior calyx? Once we identify it, how do we determine the site of skin puncture? How do we determine the angle of puncture or the trajectory of our puncture? And finally, how do we ascertain the depth at which we are going to hit the kidney? So there is no ambiguity about the fact that for good access, we need to puncture the posterior calyx. And all these steps are very important because the gateway to success or disaster is a good percutaneous renal access. If the access is gone wrong, the entire surgery goes wrong. But if the access is straightforward, smooth, the surgery usually is a cakewalk. So though there are some recent articles in the literature by Liestikos and group regarding puncturing the infundibulum, at present we should be clear that the calyx that we intend to puncture should be the posterior calyx. But which is the posterior calyx? Now, if we look at the studies by Sampaio, he mentioned that 27.8% of the times the anterior calyces are the lateral, 19% of the times the posterior calyces are lateral, and 53% of the times the calyces are superimposed on one another in varied position. So the old teaching which was there from the 6th or 7th edition of Campbell, that is the end-on calyx is the posterior calyx, is not correct. If you look at the calyceal orientation, the easiest thing to remember is that the middle calyces are the only one where there is a classical anterior and posterior orientation, while the upper and lower pole calyces are oriented towards their respective poles. So what we need to understand is what is the orientation of the poles. The kidneys have a dorsal tilt. The upper pole is much more medial and much more posterior than the lower pole. So when you make a puncture of the upper pole in prone PCNL, the track will be shorter if you are puncturing the upper pole calyx. And the lower pole is anterior to the upper pole and tends to fall much more anteriorly in prone position. Now, this particular photograph, which I had taken from an article by R.C. Smith, it shows clearly, if you see the right hand side of the photograph, it shows the tilt of the calyces. And this will give us an understanding that how the upper pole is tilted much more posteriorly and the lower pole is dropping down much more anteriorly. So in simple words, the middle pole is having the most ideal orientation of anterior and posterior calyx. In the upper pole, virtually all the calyces are inclined posteriorly, and this fact is emphasized and ascertained by CT scan studies done by a number of urologists where articles are there using CT scan. And it's the lower pole which is having the most complex arrangement of calyces. So how do we identify the posterior calyx in lower pole? Because in the middle pole, it would be relatively easy. in the upper pole, it is all the calyces are posterior calyces, and what we need to puncture is the posterolateral calyx, not the posteromedial calyx, because the chances of injuring the posterior segmental artery becomes very high if we puncture the medialmost upper pole calyx. So in the upper pole, it is the lateral calyx which we are puncturing, and usually you see only two calyces in the upper pole. Middle pole, you would be able to identify the anterior and posterior calyces, but it's the lower pole which is the most complicated. For this, I would like to quote the study by Eisner, which was published in Journal of Endourology in October 2009. He said that the anterior facing calyces, sometimes the arrangement is so complex that some calyces are either facing anteriorly. So you may get two calyces, one is more anteriorly facing and other is less anteriorly facing, or you may get a classical anterior and posterior arrangement of calyces. So what they did was they did CT scan studies of 101 kidneys, and they found that the most medial calyx in the lower pole, 94% of them were the anterior calyces. Now, if the lower pole had two calyces, the medialmost one, that is the first one, if you start counting it from the medial aspect, the first one, that is the medialmost one, 95% of the times would be an anterior calyx. And the second one would be a posterior calyx 93% of the times. What in simple words it means is that if you are doing an RGP and you see two calyces in the lower pole, you puncture the second calyx from the medial side. That would be a posterior calyx, and you would be right 93% of the times. If there are three calyces in the lower pole, then the second one,
Can you repeat the previous slide, sir? Can you repeat the previous slide?
Yeah. So
Yeah,
if
please.
you are looking at the lower pole and you find two calyces from the medial side, the second calyx would be a posterior calyx 93% of the times.
Okay.
Now,
Just
if
because
the
it's lateral?
pardon?
Just because it is lateral?
No, sir. This is based on the studies where they studied the CT scans, and they found that this is the arrangement. That the
But,
second calyx is,
in a given case,
yes,
presumption that this is posterior anterior is can be forgotten. For example, today you taught. After 10 days, I may forget that. So your talk will make us how practically to decide which is posterior, isn't it?
exactly, sir.
Yes.
Exactly.
Yes. Yes. Yes.
Now, if there are three calyces in the lower pole, this second calyx, so you start counting from the medial aspect, first, second, and third. The second one is likely to be a posterior calyx 70% of the times. So if there are three calyces, which are as they are seen here, 1, 2, and 3, the second one is likely to be a posterior calyx 70% of the times. Now, this is based on CT scan studies in 101 patients. But sometimes, practically speaking, you get such a complex arrangement of calyces in the lower pole that it is really difficult. So certain things which I do is, in supine position, when we are doing the RGP, you instill contrast, and the calyx which is filling first and is most dense is the posterior calyx. But most often what happens that we put the ureteric catheter and we make the patient prone. Once we make the patient prone, we start instilling the contrast, and during contrast instillation, the calyx which is filling up later and is fainter is the posterior calyx.
So should we fill later or before? To be honest.
Sir, at
I
my
will be
place,
asking, interrupting the question. Don't mind.
sir,
I will be
I
going
would love that. I would love that
because
because that will make the things more
I'm
clearer.
going in a student form, and I'm thinking sometimes we inject and then we rotate and suddenly stone will not be seen. All the problem. Sometimes we
Exactly.
inject because the ureteric catheter position may be dislodged. So
Sir,
you give clarity on that.
very correct, sir. And I would love if you keep on interrupting me because that would help in clarifying a lot of small little points. Sir, it all depends upon what the IVU findings are. Sometimes the IVU findings are such that it's a conglomeration of calyces over there. And in that scenario, I would put in contrast initially so that I know See, more than the calyx,
Again,
which is
again,
fainter.
I'm interrupting. Sorry, we are
Yeah,
not
yeah.
doing IVU. We are not doing IVU. You
Yes,
are
sir.
doing it. We have forgotten doing IVUs. Honestly, sorry to say, we are depending on RGP so much.
Yes.
So, does CT give any clue that before turning the patient? Because once you turn, if you inject while surgeon seeing it, like you said, one which is faintly filling is posterior.
Yes,
Is it
sir.
better?
CT scan would definitely give you an idea, but then the CT scan should have been done by a person who knows what the urologist wants. Because very often, my problem is that they come with a CT scan where there are very limited cuts, and honestly, I don't get a
Yeah, yeah. Yes,
correct idea.
yes.
So, for a beginner, I would say ki the simplest way would be make the patient prone, start instilling
Okay.
the contrast, and
Under the
use under fluoro and
underflow.
use a diluted contrast, diluted in the ratio of 1:3. That is one part of contrast and three parts of saline. And the
Okay.
calyx which fills later and is fainter is the posterior calyx.
Yeah.
Now, if still you are not sure, the other way would be tilt the siam 30 degrees away from the surgeon. With
Hmm.
the siam at 0 degree, tilt the siam 30 degrees away from the surgeon, away from yourself. And I always say, you remember MALP. MALP is medial is anterior, and what is coming towards you, that is laterally, is posterior when you rotate the siam away from you.
That to Siam again one point is there. So Siam has two components. One is the receiving end, another is a raise arising end. So
Yes,
receive you are telling the topmost part going away.
topmost part should move away from you.
Yeah. So normally people will move topmost parts towards you. On the
Yes,
other way around, you are telling topmost part should go away from you. The
correct.
one which is going laterally is
Yes, what comes towards you is the posterior calyx.
laterally means towards you.
Yes. So this concept can be better explained by these figures from Smith's textbook of endourology, that we are seeing three calyces and we really don't know which is the posterior calyx because this is with siam at 0 degree.
Yeah.
Now, when the siam is rotated towards the surgeon, as is done in a bullseye technique, the posterior calyx will move away and shorten. And this was what was described in the older editions of Campbell as lateral is anterior and medial is posterior. But the moment the calyx goes more medially, it becomes more complicated because there are blotches of contrast present over there, and you honestly cannot pinpoint which is the calyx. So, a better way is the siam is rotated 30 degrees away from the surgeon. So
Okay.
what comes towards the surgeon is the posterior calyx. I think I
And,
have made it clear,
and
sir.
usually it is more thicker, you mean to
Yes,
say.
sir. Yeah. So
So to avoid the blanching effect of the double contrast effect on the Siam, you say that just remember to go opposite side. The Siam should be moved, top part should be moved away from the surgeon. If
yes,
the calyx is moving towards you, I mean laterally,
yes,
that will be posterior calyx.
correct, sir. Correct.
Okay. And usually that is because it is prone position. Uh,
Yes,
that usually takes thick contrast or light contrast, sir.
it will be lighter, sir. It will be
Light.
lighter.
Okay.
Yeah. So after that, so after these two steps, that is instilling the contrast and looking at the calyx which is fainter, or still not clear, moving the siam away from you and what the calyx coming towards you, that is the lateral most calyx being the posterior calyx. Still, if there is some confusion, then and then only one should try instilling a minimum amount of air, because sometimes there are number of case reports where there has been air embolism when contrast air has been injected in a system which is under a lot of pressure. So this is the last resort to be used, that is using air. And the posterior calyx will be lighter, is the air being lighter fills up the posterior calyx.
Sanjay Deshpande sir is also listening the talk. He said good morning. He has
Yeah.
also a different version of this concept. You are
Yes,
telling the puncture techniques and he tells about how to identify the movements of the Siam.
movements of the siam.
Yes, sir.
Yeah, so this is the first part of my talk, that is how do we identify a posterior calyx. Now, the second part would be on the puncturing technique. And the European Society of Urotechnology has described that fluoroscopy guided prone percutaneous renal access is divided into two types, monoplanar and biplanar. And in biplanar, they have described three techniques: bullseye technique, triangulation technique, and the hybrid technique, which is a combination of bullseye and the triangulation technique. Now, whenever we do a puncture, there are three things which come into play: the site from where we start making the puncture, the trajectory, that is the angle of our puncture, and the depth at which we are going to hit the calyx. Now, in the bullseye technique, what we do is we localize the calyx that we are going to puncture, and then we rotate the C-arm 30 degrees towards ourselves. So the upper part of the C-arm comes towards us. And then we hold the needle in such a way that it is looking as a dot on the fluoroscopic monitor. And this gives us the site of skin puncture as well as the angle of puncture. So to elaborate it further, when we move the C-arm towards us and we hold the needle using a needle holder, and there are some people who have developed special needle holders for it also, we hold the needle in such a way that it is looking as a dot on the C-arm. Now, lot of textbooks tend to mention that when you want to fix the target, you move the C-arm 30 degrees towards yourself. And when you want to ascertain the depth, you bring the C-arm to 0 degrees. And honestly, I never ever could understand this, and I do not agree with this concept, which is given in a lot of articles and books. The best way to know the site of entry would be when you rotate the C-arm towards you. But if you want to know the depth perception, the C-arm should be rotated away from yourself. So from 0 degree, you take it away from you by 10 degrees, 30 degrees, 20 degrees is immaterial, because then the posterior calyx is moving towards you. And then you are able to gauge the correct depth. And this is exemplified in this excellent article by Raymond Coe, which is there in British Journal of Urology 2008. And any person who wants to read about bullseye technique, I would strongly recommend this article. The advantages of bullseye technique are the site of puncture can be determined and you know the angle of puncture also. But the axis is not aligned with the infundibulum. And especially if you are tackling stagon, this is really a problem, because then by moving the rigid nephroscope, you tend to cause a lot of torque on the renal parenchyma. And if the patient has had undergone any previous surgery or has had adhesions because of infection, then this torque causes a lot of trauma to the renal parenchyma. There are chances of more bleeding. And another problem with bullseye technique is, all said and done, over a period of time, the surgeons with their tactile perception are able to know that they have punctured the calyx, but the depth perception is quite difficult.
I agree with this. Perception is not there.
Yeah. So if we compare the triangulation and the bullseye technique, there has been only one paper which has been published by Tepler et al. In 2012. And they found no difference in the operating time, fluoroscopic screening time, the duration of hospitalization, and the blood transfusion rate. But there was a small drop in the hematocrit in the bullseye technique, more as compared to the triangulation technique. And the complication rate was slightly more, though they mentioned that it is statistically not significant. But it is my personal opinion that in a stagon stone, trying to approach something with a bullseye technique causes a lot of torque on the renal parenchyma, and I would strictly avoid doing that. Now, if we look at what are the criteria of a good puncture, the Smith's textbook of endourology, the article by Nobarto mentions that the axis should be from the posterolateral position, that is the posterolateral calyx. It should be through the renal parenchyma. It should be towards the center of the posterolateral calyx. It should be directed towards the center of the renal pelvis. And the trajectory should be such that it should not damage any major blood vessel. So if you look at all these 5 criteria, it is very obvious that the Bullseye technique does not fulfill these criteria. It is not directed towards the center of the renal pelvis. So coming to triangulation technique. Now, if we ask most of the students, they would answer by saying that triangulation technique is puncturing along the stone axis. But triangulation by definition is using 2 known points of reference to locate a third unknown point. Now, in PCNL, the unknown point is the target calyx because it is at the depth. And as Dr. Chandramohan mentioned at the start of this session, that it is a semi-blind procedure because you are not having a depth perception. And in PCNL, when we are making a fluoroscopy guided puncture, the 2 known points of reference are the point on skin corresponding to the targeted calyx and the point of skin puncture. So we know these 2 points, and utilizing these 2 points, we are going towards the third point, that is the target calyx, and this is triangulation technique. Now imagine this is the calyx which we want to puncture. Now this calyx can be punctured from multiple points over the skin. And as you notice, each particular point will produce a different angle. And this particular angle may increase the torque on the renal parenchyma or may cause damage to the infundibulum as you are puncturing. So if you look at a particular thing, that why the site of skin puncture and thus the angle of puncture become important is because if you look, there are multiple areas from where you can make a puncture. But one area which will be the perfect area would be which will give you a correct access to the posterior calyx and give a straight access where you can clear the maximum amount of stone burden, especially in a stagon calculus. So that brings us to the point, how do we select the skin site for puncture in triangulation technique? Interestingly, there were a lot of things mentioned in literature, but the first paper, and probably I think the only paper which is written on this has been by us, which was published in 2009 in the Journal of Endourology. And after that, it got quoted in Smith's textbook of endourology and is described as the hybrid technique. Now, this utilizes the principles of Bullseye technique and the triangulation technique. Now, let us go step by step as regards how do we puncture the lower pole, upper pole, and the mid pole. Now, how do we select the skin puncture for lower pole? Now, consider this particular partial stagon calculus, and on the right hand side, this is an IVU film which shows grade 2 to 3 degree of hydronephrosis and a lot of calyces. So in triangulation technique, we want to go in line with the infundibulum so that we can reach the stone and achieve a good clearance. So what I do is, with the Siam at 0 degree, I mark the calyx on the skin which I am intending to puncture. And this particular point is the point A. Now I rotate the Siam 30 degrees towards myself as we do in Bullseye technique. And when we rotate it 30 degrees towards me and I hold the needle in such a way that it forms a bullseye on the Siam monitor, I mark that particular point as the point B. So now I am having 2 points on the skin surface. The point A, which is corresponding to the skin, the point A is on the skin, which corresponds to the calyx which I want to puncture, and the Siam is at 0 degree. When I rotate the Siam 30 degrees towards myself, utilizing the Bullseye principle, I get the second point, that is point B. So now there are 2 points which I am having, A and B. So this is what I get on the back of the patient, the point A and B. Now, mathematically, we know that A is the center we want to reach from the periphery of any circle. The radius remains the same. You can go from any point. The radius remains the same. And now what we are having is, we have the point A and the point B, which is the distance AB is the radius of the circle or the radius of the sphere. Now in triangulation technique, I want to go in the line of the infundibulum. So what I do is I draw a straight simple line. The point A to B distance is measured, and this is marked on that line as the point B1. In simple words, what it means is the distance from A to B is the same as the distance from A to B1. So this is the radius which I am using. So this is the mathematical principle which I use to determine the site of skin puncture. I will elaborate it further by help of some figures. This is the point A. This is the point B. This is the line which is there. And this is what I have measured. Now, this distance from A to B is marked in this line, and this B1 is the point from where I would be making the puncture for the lower pole. I think, sir, I have made it clear.
Yeah, I am going very closely. Like I'm seriously depth into the depth of it. I can understand the point which I never followed this. I have never listened this. We were doing it. The main point is B1.
Yes, sir.
B1 is an imagination point.
Yes, sir.
You can keep anywhere on the skin.
Hmm.
If you go bullseye, B is the point. If your end point is A, you have to reach A destination at any cost.
Yes.
So from B, other than B, to choose the angle in line with the infundibulum is the crux for PCNL.
Yes.
So everybody can keep A line easily.
Yes.
You just keep the needle straight. A line will be there at the tip of the calyx wherever you want to puncture.
Very true, sir.
B line is little tricky thing where same calyx can you see in Siam when you turn 30 degrees. Sometimes we confuse which calyx we have seen, but it's okay. Most of the times we can choose, and how the B line will move I am not able to understand because I don't do that. So B line is naturally bullseye aiming that calyx.
Correct,
So
sir.
that distance you should have clear cut idea. With ureteric catheter you can measure, and now you go back to 0 degree, put the axis of the in the axis of the line and exactly measure that amount of the length and go from the puncture there. I'm
Perfect, sir.
understanding it. Perfect.
Perfect, sir.
Yeah.
Now, for the midpole, determining the site of skin puncture is easiest, because once you rotate it towards you, there is no, the infundibulum is in the same straight line. So it is the point B only. And in the upper pole also, because a lot of people try to avoid going above the rib, 12th rib, or so I don't have any such inhibition. And I follow the same principle that I use for the lower pole puncture, even for the upper pole. Only care that I take is I try to avoid going above the 10th rib as far as possible. It is either supra 12th or it is supra 11th. It is preferably never supra 10th.
Yeah.
Now, once we have determined the site of skin puncture, the next component is how do we make the trajectory or determine the angle of puncture. And this again was published by us in the Indian Journal of Urology in 2015. And sir, I would like to give a lot of credit to my wife, Dr. Anshu, who has helped me in developing this mathematical principle. Her maths is far better than mine.
Great.
Now, sir, in bullseye technique, when we are holding the needle at the point B and we are creating a bullseye on the fluoroscopic screen, it means that the needle is at a certain angle. And it is this angle which we measure using a protractor. Now, once we have this angle, suppose this angle is 55 degrees. The same angle is used for making a puncture at the point B1, as you can see in this.
Repeat, sir. Go to previous slide. Sorry,
Yeah. Now, once we rotate the Siam towards ourselves and we are at the point B and we are marking the point B, we hold the needle in such a way that it forms a dot on the fluoroscopic monitor. That is bullseye.
Like bullseye, bullseye.
Yeah. Now, at this particular point, I measure that angle of
Whatever
the
the angle, whatever
angle,
the
whatever
angle.
angle. And I
Yeah.
have found this angle to vary from 45 to 65, sometimes 70 degree
Sometimes
also.
90 also.
Uh, Less
80.
likely. My
80.
experience has been 45 to 70 degree, but most of the times it is between 55 to 65.
Okay.
So at this angle we measure. Imagine that this angle is 55 degree.
Yeah. Now
Now
you
the
get this.
same angle which I have measured at the point B, I am going to use it at the point B1.
Okay.
Now somebody may argue that the counters of the kidney are not flat. There is the counters of the back are also not flat. So there will be some variation of about couple of degrees. And this question was asked to me by a lot of people whenever I made this presentation. And I have found an answer to this because I practically never found any difference. It couple of degrees honestly do not make a difference. And this was found mathematically also not to make a difference by an article which was published where they used CT scan to calculate the angle of puncture. And they found that if you take the point of skin puncture by some degrees away, by 30-40 degrees, the angle of puncture changes by only couple of degrees. So the same angle is used. And from the point B1, I start making an entry. I think that is clear, sir. Can I go ahead?
Yes, 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 yes. Same
Now,
B, the angle you are deciding on bullseye, same angle you
same
have.
angle I am using at B1.
Yes.
Now,
If
we
you
have
don't,
covered two
bullseye is
aspects.
not useful, but you have taken a lot of points from bullseye. You
Yeah.
don't want to puncture at the site of B1. That is your point.
At the point B, I
At the
start
point B,
puncturing at
you
the
don't
point
want to
B1.
puncture. Yeah, B1 is your favorite, not B.
Yes, yes.
Because it
Now,
is in line with the see, bullseye aims only the calyx. It does not think
yes,
about anything else.
correct.
Forget about kidney, stone, it doesn't bother. Whereas
Yes,
B1 will take the axis, angle, in line with the pelvis and taking large chunk of the stone burden with the ease. That is the difference.
sorry. If we look at the 5 criteria for a good ideal puncture,
That
as
slide is
mentioned,
very important. That slide is
those
very important.
those criteria are fulfilled only by the triangulation technique.
Yeah, yeah. Even I am a triangulation surgeon today, so
Yes.
nothing to argue with you. I will go with you.
So, out of the 3 important things for a good percutaneous renal access, that is the site of skin puncture, angle of puncture, I think I have made it clear. The third aspect is how do we determine the depth of puncture? Now, there are 3 ways in which it can be done. We can mathematically calculate the depth. We can use the angle determined by using the protractor, or we can use the movements of the Siam. For a beginner, I would recommend that you start calculating the depth, especially if it's an obese patient, because I have found it very useful to calculate the depth, especially in obese patient, because I know what size of implant sheath I need to use. I will just elaborate in short all these 3 aspects. Now, again, determining the depth of puncture mathematically was first described by us in 2015. And we used the principle of law of sines using the universal triangle solver. There is an app which is available, and any person, I won't go into the details of the mathematical aspects in this particular talk. There is an app available on Play Store, which is a universal triangle solver. So when you are measuring the distance, you are knowing one side of a triangle. You know one angle which is at 0 degrees, 90 degree. The other angle you are measuring with the help of a protractor. And the third angle is easy to determine and the depth can be calculated. The group of Liasticos proposed another way in which they calculate the depth of the triangle, and they used this hybrid technique for the same. And this particular video is also available free on the YouTube, where the European section of Eurotechnology described the calculation of the depth by using the principle of circumference of the circle. And they say that the distance AB, if you multiply it by 12 and divide it by pi, that is 6.2 pi, that is 6.28, it gives you the depth of the target calyx. And this also comes to be roughly accurate. But the easiest way, I think, is if you have determined the angle, you use that angle, and all of us surgeons have extremely good tactile sensations. The back feed, the tactile perception, we are able to appreciate really well, and we can very easily know that we have punctured the calyx. But there are certain things we need to understand. We need to measure the site of skin puncture and angle in the same phase of respiration, and we do it in end expiration. It is always better to take the help of your assistant or anesthesiologist to see the angle on the protractor, because you are holding the needle, and the moment you try to look at the protractor, your hand moves a bit, and then the angle may be disturbed. So you keep on looking at the fluoroscopic monitor, you maintain the bullseye, and ask the anesthetist to have a look at the angle. And after a couple of times, honestly, I would say that I have seen with some of the juniors also who have been associated with me, that they, with that angle, they are able to go inside and they know that they have punctured the calyx. Now, I'll give you two small videos which depict this particular principle. Here you can see a large radio-opaque calculus at the PUJ with a radiolucent calculus which is filling the entire calyx and lower pole calyces. Now, when we are instilling the contrast, if you see, there is a calyx here which is getting filled later and is fainter. So this is the posterior calyx. And with the Siam at 0 degree, I have marked the point A on the back of the skin. Now the Siam is 30 degrees towards me, and I hold the needle with the help of a needle holder in a way that it forms a bullseye. I use a protractor to measure the angle, and I use that angle to make an entry into that calyx. Right. And when I'm making the entry, I have brought the Siam back to 0 degree. And a free flow of urine confirms without any bleed. If the urine is coming, it's a very satisfying thing. And the guide wire walks in. And for the beginners, I would recommend that when you start making the dilatations using whichever technique, I used to use the protractor because that helped me in causing minimum trauma to the surrounding structures. I would show you a second video where there are multiple calculi which is filling the entire system. There are calyces. This person had undergone PCNL at some other place and had come to me. Now here also you see the calyx which is filling later and is fainter is the posterior calyx. Now this is the point A which has been marked. Now the Siam rotated towards me. This is the point B. The protractor is being used to measure the angle, and you can see the shadow of the protractor over there. And then I want to use the triangulation technique. I go in the line of the infundibulum and I mark the point B1 in such a way that the distance from A to B is the same as the distance from A to B1. At the point B1, using the angle which I have determined using the protractor, I make the puncture and I have entered. And the best feeling that you get is the guide wire just walks in. And the same angle is used when you are using the metal dilators or passing an emplast sheath. Now the third way, which sometimes happens, see, in the best of hands, with the most experienced surgeons, we all have experienced that you use whatever technique. Sometimes you get a puncture in single shot and sometimes you are not able to get that puncture. It has been my experience that using the protractor, I have been able to make a single shot puncture in more than 95% of cases. But sometimes all of us face problems. And then we look back at our age-old technique of moving the Siam from 0 to 30 degrees and using the Siam to gauge the depth. So for the persons who do PCNL, everybody knows that the medial and lateral adjustments of the siam are done, of the needle are done with the siam at 0 degree. So we are moving the needle medially and laterally with the siam at 0 degree. When we have tilted the siam in a cephalocaudal direction by 30 degree, then we make the movements in the antero-posterior direction. So the depth perception comes by moving the needle in the up and down manner with the siam tilted cephalocaudally by 30 degree. What we need to understand is we should make the needle adjustment in one plane while keeping its direction in the other plane fixed. So if you are making up and down movement, the medial and lateral movement should not happen. And when you are making medial and lateral movement, the up and down movement should not happen. And this is the step which is most difficult to master. And this is the reason why literature has mentioned that you need more than 60 cases to overcome the learning curve in PCNL. We also need to remember that the adjustments should be made when the needle is outside the renal capsule and not when it is within the parenchyma. Otherwise, it will traumatize the parenchyma and cause bleeding. Now, when the
Can you show the previous slide, sir?
Pardon?
Do not make adjustment with the needle in the Okay. So
Yeah.
here you are showing a calyx, most inferior calyx.
Yeah.
Most inferior.
Sir,
Do you think all your principles can be applied for that arrow mark
no,
which
sir.
you have shown?
No, sir. I'll tell you. This is from this is from the 6th edition of Campbell.
Yeah.
And I have used this particular photograph to tell few of my juniors that this is the calyx which you should never puncture.
If that is the calyx which is not accessible by RIRS for a small stone, it will really take away your
Sir, the
energy.
easiest way to approach a stone would be to go from the calyx above here
Yeah, a little
and
above.
then reach here.
Yeah. So never try to go directly there.
Correct. Medial most calyx in the lower pole, I would never puncture because that's the anterior most calyx.
Yeah, that's not at all. That's a very, very important point, sir. For the juniors who are nearly 220 audience are there, medial lower chances of bleeding is very high.
Very high.
And the accuracy of passing the guide wire with an angle towards the pelvis is not possible. You need a lot of skill, and it should be end dilatation. You can't do this dilatation to pelvis again
Yes.
because it's a lot of angle. Anyway, that's a different issue. Thank you, sir. Good picture you have shared.
Sir, now another point which I want to emphasize is that you cannot assess the depth with the siam at 0 degree because you will
Yes, sir.
see everything would appear the same.
So
So what is the
in that case, I interrupt again. A lot of people, my close friend Arshavardhan says I do in monoplonar. That
Yes.
does not have any scientific. I personally feel it is your clinical experience, but not scientific. Majority of us do a puncture with movement and feeling it and then going it. But if you
Sir,
really want to know medial, anterior, or posterior, you have to rotate at least once. Depth.
sir, I fully agree with you because over a period by experience we develop a sort of a muscle memory. And we
Yeah.
know this is the direction, this is the angle.
Yeah.
Why I came up with because I faced these problems when I started doing PCNL. And I thought these were the 3 important things which a beginner has to master. And that would significantly decrease his learning curve. Over a
Yes.
period, you do 100 times, you would gain mastery. But suppose you gain mastery by doing 10 cases, that would boost up your confidence in a great way.
But when there is difficulty, there is no harm in whatever angle you are familiar with, rotate, see it,
Yes,
and then reassess, happily puncture the end calyx which you are desired.
right.
You have desired. Yes, sir.
One way which I picked up from Dr. Kaushik Shah, which he used to do, is a very easy way of determining the depth. And then I would tell what I do sometimes. You place another needle on the skin surface over the target calyx. So when you are making a puncture, you put another small needle on the back over the target calyx. Now, if the calyx is between the 2 needles, then the puncture needle is deep and should be adjusted superficially. And if the target calyx is above the two needles, then the puncture needle is superficial and should be adjusted towards the depth. It is confusing, sir. I would show a small video which will make it clear. The simplest way which I would tell to all the juniors would be, if your needle is below the target calyx, you are anterior. If your needle is above the target calyx, you are posterior. So this is what I have written, that if the needle is above the calyx, then it is below in depth, that is, it is more posterior, you should go superficial. And if the needle is seen below the calyx,
Sir, but the only objection I have this
yes,
is in relation to the Siam movement in one particular direction.
cephalocaudal at 30 degrees.
Now, this is very important. This
So
is fixed.
you tilt the Siam from 0 to 30 degrees cephalocaudally, and you look at the needle. If the needle is below the calyx, it means you are more anterior, more superficial, you should go more deep. And if you are below the above the calyx, it means you are more posteriorly, you should be more anterior. And I will show a video which I have prepared using the rubber stoppers over our bottles. This I kept it under a foam. With the Siam at 0 degrees, I am making a puncture. I am not sure whether I am in the calyx. So a second needle is placed with the Siam at 0 degree. I make a puncture. What has happened? I am above that calyx, which means I am more posterior. So I need to adjust it more superficially, more anteriorly, and then make a puncture. And I am hitting the calyx. The second scenario is I have made the puncture. I am not sure. The Siam is at 0 degree. So now I rotate the Siam 30 degrees cephalocaudally after putting a second needle. And when I make a puncture, I am below that calyx. So below means I am more superficial. I need to go more in the depth. And I make a puncture and I am hitting the calyx. You can see the indentation of that rubber stop.
Yeah. So in other way around,
Now, the simplest thing which I would recommend is, if sir, it's a very crude way of putting it up. Remember your BAP, B-A-A-P. If it is below, if your needle is below the calyx, it is anterior, that is more superficial. If it is above the calyx, it means it is more posterior. So you adjust accordingly. It is the easiest way to remember. You can remember it as ABBA also, that if it is above, it means you are below, go superficially. If the needle is below the calyx, it means you are more superficial, you should go more at the depth.
should I add a small point with your permission?
Sure, sir. Sure, sir.
But the concept, your concept is correct. Only thing is that you are saying BOP, ABBA like that.
Yeah.
But I say, even if you don't remember, whichever way you rotate, cephalocaudal, whichever way you rotate,
Correct.
you withdraw and trial and error. You try to go in other angle towards the calyx by rotating anterior and posterior. If
Yes.
you go more anterior, you will go far off the target. Then come anterior, like driving. You are driving RGP. You try to go right side. It's not going towards calyx. Then you go left side. So
Yeah.
after some time, you'll understand. So mainly two directions are very important. 0 degree you assess, 30 degree you puncture. Again come to 0 degree and assess whether your depth is correct or not.
Perfect. Perfect, sir.
Perfect.
Yes, sir. So
Right.
I think that's the end of my presentation, sir. I would be happy to answer any
So,
queries. Any
I will
questions.
ask a lot of questions, quick fire questions. We
Sure,
will
sir.
face because 246 have attended and a lot of audience are there. First, only question from the audience is Vinu. Yes, respects sir, kindly conduct a hands-on workshop in a will be helpful for PGs. You conduct it, sir. Better.
Definitely,
Same
definitely.
every 6 monthly once you conduct it, it will be very useful. Now I am asking you quick questions, sir.
Yes, sir.
Number one, whenever you are puncturing a calyx,
Mm,
three aspects I will give choice. One is the most in prone, most posterior,
mm,
most lateral,
mm.
and most straight track. Which one is the most important thing? Because when I teach my fellows, I say that these three, if you can satisfy, that is the best puncture. It should be most posterior, that means most superficial.
Yes.
Second is it should be most lateral, which in the given calyx. And third thing, it should be a slightly straight track so that the depth will be, I mean, thickness of parenchyma is less. Among these things, how do you address? Like, for example, posterior medial calyx is there.
Yes.
Posterior medial. Will you hesitate to puncture if it is falling in line?
Sir, in the lower pole, once I identify the posterior calyx, I followed the principles which I have mentioned. And
So,
honestly speaking, these satisfy all the three criteria that you have mentioned, and the
yes, yes.
puncture is obtained.
So you mean to say that posterior calyx is the crux?
You have to identify the correct calyx.
Same thing,
If
you are a
you,
supine PCNL surgeon also. In the
yes,
West Zone also, we have a debate on that. We have a symposium on that.
yes,
What is your point in triangulation supine PCNL? Will you try always anterior?
sir, in supine PCNL, I think you would also agree with that. It honestly doesn't make a difference whether you make a puncture of the anterior or posterior calyx,
Yes, because
because
you come laterally.
you come laterally, and when you have given a tilt, both the calyces are looking in such a way that whether you puncture this or this, it doesn't make much of a
You have
difference.
access to both easily, in
Both the
fact,
calyx easily. And
easily.
it's so in I would follow the triangulation principle even in the supine PCNL, but sometimes there are some calyces in some patients where it is impossible to puncture in the lower
Yeah.
pole because they are so
Yes.
difficult.
Lower pole supine is difficult. Lower
Yeah,
pole prone
some of them.
is my opinion.
Yes, sir. Yes, sir. And some of these calyces are, you cannot puncture it in a triangulation
Not
technique.
penetrate in prone supine PCNL.
But what I have found in supine PCNL is that in these scenarios, if you puncture the other calyx, because here it makes no difference whether you are puncturing an anterior or posterior calyx,
Or posterior.
you are able to really achieve. And even from, suppose I use the same article of Isner, that is in prone, the second calyx is the posterior calyx.
Yeah.
If there are three calyces, you take the third calyx, which is anterior. In supine PCNL, you can puncture even that calyx and still go into the upper pole very easily.
Yes, 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 yes. Because you are horizontal track.
Absolutely.
Your angle of puncture is not this type of 45 degrees angulated. It
Not at
is
all.
it is parallel with the ground.
Yes.
Most of the times it is parallel with the ground.
Very
Yes,
true.
second question. Sometimes you try all the measures,
Yeah.
0, 30, it appears that it is there, but the saline will not come out.
Yes, sir.
Saline
It
will
does
not
happen.
come out. I- I-
This does happen, sir. Once in a while with everybody.
Then you feel
Especially
that all these angles are useless. We should not feel like that actually.
no, no, sir. This usually happens if you have made a correct puncture. Everything appears perfect and you are still not getting the free flow of saline. It usually happens when the calyx is so blocked because of the stone, especially in a complete stagon, that nothing comes out. But in these scenarios, I think you must have also experienced that you are able to virtually feel the stone because the moment you have punctured the calyx, you have hit the stone. So I distinctly remember on couple of occasions that I have tried passing a glide wire straight away because I knew I am feeling the stone. I do not put the contrast straight away because suppose by misfortune I am outside, that would result in extravasation and then
Oh,
nothing is
sir,
then
I
nothing is
strongly feel installation of the contrast through the
needle
sometimes
is dangerous.
through the needle. I will put the guide wire and try if at all I am
Yes.
confident, but not the
I
contrast
do
inside.
that. This has happened to me only a couple of weeks back. I was dead sure that I am inside, but the water was not coming. Urine was not coming. So I passed a glide wire. Little bit of manipulation and it had gone into the
Because
ureter. So I knew
I
that
think
everything was
the
fine.
answer for both of us problem is the mucosa and submucosa missing the bus little bit is the
Yes.
reason. Submucosa, somewhere needle might have struck and our guide wire will not go into. You should not get frustrated.
Exactly.
Repeatedly attempt one or two, three, four attempts. You will definitely pass if you follow the principles.
Correct, sir.
Third question from Purnanandam sir. If the stone is on an anterior middle calyx, it's a good question actually. Most difficult case will be anterior middle calyx stone, which is small with long infundibulum. This will
Mhm.
really give trick. So he
Yeah.
is asking if such stone is there, do you like to still go from the posterior calyx or directly puncture the anterior calyx? Stone is not big, infundibula are long. I hope you are understanding. It's
Yes,
a
yes, yes, yes.
theoretical question, but it can happen in a
And
meeting
what
sometimes.
he has put up a scenario where he is excluding the use of RIRS by saying that it's a very long
RRS is the only option in that. Actually, I am telling little dogmatically, RRS is
if
very easy in such case.
somebody wants to really do it by mini perk itself, I think supine PCNL would be the easiest option.
Yes, yes. Supine PCL directly you can go to the anterior calyx also. That is answer. But
Yes,
if you are prone, puncturing anterior calyx in prone is a little risky
risky. It
because
is risky.
some vessels will come in between and you have to be really careful in
Yes.
puncturing the anterior middle calyx.
Solitary calculus, where on the imaging I feel ki I cannot go from the posterior into an anterior. Somebody may argue saying you use a flexible nephroscope and I don't have a
No,
flexible
no, no, no.
nephroscope. I think the best option is supine PCN.
Flexible nephroscope will not help if you, the
It will
CT
not help.
shows clearly long infundibulum, RGP shows long infundibulum, go for supine PCNL. This is one
Yes,
area. RIRS is first option, second option is supine PCNL.
supine PCNL.
I think this is a very good question asked. Now, I like to ask in routine OT, if you have a staghorn with multiple calyces in the lower, middle, and upper,
Hmm.
do you think that large dilated system is there?
Hmm.
Majority of this says that go supracostal, puncture the lateral or medial posterior calyx, you can get maximum access to the entire kidney.
Yes,
Do you believe it? Is there any doubt in that? No doubt.
no doubt, sir. I told you right at the beginning
Yeah.
that more than 70% of my punctures are supracostal. I
So,
think that's a
so
fabulous
in prone
approach.
PCNL, you say that supracostal one should not hesitate. It gives
Not at
access.
all.
And the only thing is that don't go nearer to the infundibulum. Stick on to the basic principles of calyx, calyx, calyx.
Sir, upper pole puncture, I would say in prone PCNL, always puncture the lateral calyx, upper lateral
Mm.
calyx. Always make the puncture in prone, in end expiration, and do not have the fear that you will create a pleural violation, pneumothorax, hydrothorax. The incidence is pretty less. I
Pretty
would,
less, even if it is there, all our MBBS days we used to put chest tube known without any helper. Very
very rare,
rarely, lifetime once you require pneumothorax chest tube. But this is not life threatening. You can immediately
not
do
at
it.
all.
Yes, sir. So lateral posterior part of the calyx, actually posterior anterior will not be there. If you
It is
directly
lateral,
go to lateral,
posterolateral.
posterolateral, if you go, very safe. And the guide wire also passes easily into the ureter or pelvis.
And
I agree.
another small thing that you be lateral to the mid-scapular line. So that
Yeah,
way you would avoid
better
the
to
pleura.
yeah, line.
So in
Uh,
end expiration and lateral to posterior axillary, mid-scapular line.
yeah. Do you believe if by chance if the kidney is supracostal and upper calyx is going above the 10th, making a slightly an oblique tract below the 11th rib to the upper calyx laterally will not do much harm, especially non-operated kidneys. So that you can move with the ampla sheath, you can move with nephroscope kidney down and clear all these stones.
Well, sir,
See,
there is an article from SGPGI which mentions a similar principle. That is, you make a puncture in the kidney, use that track to bring the kidney down, and then you can manipulate it. But honestly speaking, sir, such scenarios are few and far. That is
fuel.
a puncture which is above the 10th or ninth rib with some manipulation with the help of the anesthesiologist, where the movement of the kidney can be controlled in such a way that is a supra 11th puncture can do the trick in majority of the situations.
Yeah, I agree with that, sir. Next, If you have an upper calyx stone and lower calyceal stone large burden,
Mhm.
just a theoretical, it can
Yes.
happen.
Yes.
Two stones, you don't want to do RIRS, large volume.
Yeah.
ECRS, that all we are not discussing today.
Yeah.
In prone PCNL, you equal volume, मान लो 2 centimeters, 2 centimeters in the upper calyx and lower calyx, with
Mhm.
slight angulation between both of them. Going from this side to that side is difficult, that side to this side is difficult. Your
Mhm.
first puncture will be lower calyx or upper calyx.
Sir, I would go from the what I do in such scenarios is I put guide wires from both the sides.
Both
Uh,
sides.
both sides. But I
Very-
will go from the upper pole first.
Yeah.
Go from the upper pole
Upper
first.
pole.
And more than 90% of the times I will clear
You
the
can
lower
get
pole.
away, you can get away.
But in prone from lower to upper is more difficult.
Very difficult. Supine it is easy.
Easy, very easy.
So because the posterior calyx upper pole is the superficial part, most superficial part, you can enter into the lower calyx, you can enter into middle calyx
Middle
also,
calyx
you
also.
can enter into ureter also sometimes easily. That is
Yes.
the basic thing. Do you think it's a tricky question, sir? Do you think in post-operative cases, somebody undergone pyelolithotomy, somebody mobilized the kidney, do your principles still hold good, or as long as 30-degree Brodell's line tilt is there, then only your principles hold good?
Sir, basically what I am doing is I am combining the bullseye with the triangulation.
Uh,
So I have done a lot of these cases which have undergone previous pyelolithotomies, previous PCNLs also, where I know a patient who had undergone 3 PCNLs in a solitary kidney, and I was doing the fourth one, approaching from the lower pole using the same principle. And I still remember what he said, that if it is this comfortable, I don't mind having another stone. And I said, I don't want you to have another stone. So the
yes,
same principles hold true. It doesn't change at all.
yes. Coming to the most of us, it's again, you should be honest. Most of us actually aim for the uh, lateral aspect of the calyx in the convex T. When the needle enters, we push a little more inside
Yes,
towards the infundibulum. Somewhere some people, senior people also confidently go a
yeah,
little beyond the infundibulum also. Ideally it should be withdrawn up to the
yes,
periphery of the calyx and then pass a guide wire, then you are the hero on that day.
correct.
But by chance if you withdraw at the level of infundibulum, can you guarantee that you have gone through the calyx or just medial to the calyx?
Sir, this is what you have said is a very practical observation. This I have seen in a lot of workshops also. Everybody does that.
Everybody
You,
does this.
you reach the calyx and then you make a puncture. And I
Yeah.
have given this a thought. What actually happens is all everybody has a fear, probably subconsciously, that he is probably bit outside. So he wants to ascertain that he should be bit more inside. It is
Yes.
subconscious.
Yeah.
And 99.9% of the times people get away with it because by experience you know when you are going that you are not causing any trauma. You
That
are
loss of
getting that
resistance,
peace, the loss of
easy.
resistance.
Loss of resistance.
Yes,
Sir, I
but
am doing now lot of ECRS. Supine PCNL, I am seeing the puncture when junior is doing. Flexible
yes,
scopy person will be observing where he is puncturing.
yes,
Lot of it appears in calyx, but it will be lateral in the pharyngeal angle or anterior, but it's not in the medial anterior. So it is safe. So most of the times it is in the cup only. In the
correct.
cup, it may go a little bit lateral medial.
Sir, it cannot be
Perfect.
absolutely 1 millimeter, but
Absolutely on
yes,
1 millimeter. This is my observation. That's why I asked this question. So better get it from the tip periphery of the calyx. If 1 2 centimeters with experience, if you go needle, nothing will happen. Pass the guide, and especially if the fluid out is very clear, isn't it,
clear.
sir? Very clear. And in which calyx this ABB1 principle is most useful? Is it in the middle calyx or
Lower pole,
lower
lower
calyx?
pole, lower pole.
Okay.
See, sir, identifying the calyx in the upper pole is easier. Lower pole,
Mm.
it's most tricky. And in
Mm.
lower pole, it is more anterior also. Upper
Mm.
pole is more closer. The gerotas is thicker. the puncture and everything is far more easier in the upper pole as compared to the lower pole. Though a lot of people are worried about puncturing the upper pole, but honestly, upper pole is easier to puncture as compared to the lower pole.
Very important point you told. That has to be taken with open mind. Lower pole we puncture because the renal artery is away, because multiple vessels are away. We are confident somehow we go and we get away. But if little error is done in lower pole, it bleeds actually.
Yes.
Especially more than 20 French, it bleeds. One should know this A, B, B1. It's very useful. Identifying the calyx posterior is important in prone PCNL.
Yes.
Prone PCNL. If you go
Yes.
anteriorly, you go deep and unnecessarily you will invite problems because you cannot turn back into infundibulum and pelvis. If I'm not wrong, so
Correct, sir.
that's correct. Have you ever applied these B1 principle in mal-rotated ectopic kidneys like horseshoe kidney or
Yes.
little
Yes,
ectopic
sir.
kidney?
Everywhere I
Anterior,
use in prone PCNL, I use the same principle.
so it
Commonest kidney that
applies to mal-rotated also.
yes, sir. Yes, sir. Commonest kidney or anomaly that we encounter is a horseshoe kidney.
Okay.
And I have used these principles. In fact, the first benefit I had was a patient who was weighing 123 kg with a horseshoe kidney. And we were not sure whether we will need a small, that is a 16 centimeter amplas or a 20 centimeter amplas. And when I used these principles and I calculated the depth, I was sure that even with a 16 centimeter amplas, I would be very comfortably in. And it went that way.
Which company produces long amplitude?
Sir, all I use the Cook's one, 20 centimeter long.
Longer one also you get horseshoe kidney longer one also.
Yes, sir, 20 centimeters, sir, long M plus. I think everybody has used it.
99% that will do the job.
Yes, yes.
So I will sum up, sir, with your permission because this is the first time I am listening so depth. There are still audience. Total 277 after a long time. It crossed 250.
Right, sir.
Stones usually. So dear friends, on behalf of Gyan Sharma, today I am the student. Whatever I learnt, I will tell in 2-3 minutes to summarize. Sir said that if you put a 0 degree, the calyx point it as A. After that, you rotate the C arm to 30 degree. Same calyx you do end on, that is bullseye, that is point B. Wherever, let it be wherever.
Yes.
This will give distance between A and B.
Yeah.
That distance will help you in puncturing, identifying the site. So please go back to 0. Use your normal skill of axis of the which anybody can see which axis stone will be removed, infundibular pelvic axis towards the calyx. You put
Yes.
it same length which you have measured AB, you measure on the needle and then that is the site of the puncture, go inside.
Yeah.
This is the simplest way you tell and I clearly understood. Second point he told is in the depth you always see in two angles. Sir said that the C arm should be shifted to cephalocaudal. That means top part of the C arm goes towards the head end. In that case, he said that BOP B-A bath or BOP B-A
ABBA. Above is below and below is above.
above below. But what I personally feel is that you puncture in if you are doing triangulation, you puncture in 0 degree through the B2 point. After that, you shift the whichever angle you are comfortable. You see whether it is a needle in the same there or not, and you readjust. You should know what happens if you put anteriorly needle, what happens if you put posteriorly. Accordingly, you adjust the needle and safely puncture. Again, come to 0 degree, medial lateral you observe, and same with both 0 and 30 2-3 times you see, and then once you get into it, 99% you will get the water.
Sir, can I add that for beginners, you can
Yes.
measure the angle using a protractor at the point B, and then you can use the same angle at the point B
Yeah,
or B1.
yeah. The
And
only
this will make your life very easy. You know that you are very close by. And in case
yeah.
you are not able to puncture, then you make the
Yes.
cephalocaudal movements and get the puncture.
That is the third point that in the B point only because worldwide bullseye technique clearly shows the angulation in relation to this desired calyx or stone. Same angle will be there almost in the other point also taking the curvatures of 10 degrees माफी किया तो the B2 point also will have the same depth. So it will give rough idea how much depth will be there. Sir is saying that take the measurement protractor and then same depth you move it here, other person assistant, so that you can go in the same depth. So I hope most of the juniors might have understood this, because I did not use, I understood, so they might have understood. So with this, I thank once again Gyanendra Sharma sir for giving insights. I think you should explore more. You have a mathematical angle with madam. You can explore more in the ECRS as well as supine also. And in the west zone, we definitely share and learn, because you have taken the topic of CM guided supine PCNL puncture position. I am happy that I can see and learn that ultrasound guided is not. It's more subjective, whereas CM guided is more objective. Let us meet at West Zone at Nashik, and I am really thankful for your very good presentation, sir. Thank you very much.
Thank you so much, sir. I honestly enjoyed this session.
Yeah.
It has been fabulous, and your queries give an insight into the depth of your practical observations that you are having in your day-to-day practice, sir. Fantastic.
Thank you, sir.
Thank you so much, sir. Thank
So
you.
the single person maximum learning is me only in pure, because every day I will be interacting. I get lot of knowledge. I am selfish. I am learning. So let us even see these 270 people who learned. They may be juniors, and they will also apply when difficult times. They will get benefited. That's the way we help the
Sir,
junior.
can I also add that if
Sir,
the junior urologists are interested in learning more about this percutaneous renal access,
yes, sir.
including the problems that if you puncture and there is extravasation of contrast, or you are getting blood, or how do you want to avoid a colon, or how do you want to avoid a pleura? So myself and Dr. Pankaj, we have written a review article, fluoroscopic guided percutaneous renal access review article. If anybody types it on the net, it's available free, and it mentions everything that you need to know about the art of puncturing, as well as the problems that you anticipate while puncturing.
Great. Highly appreciate it, sir. See you again with one more topic of hypospadias sooner.